Good morning, everybody, and welcome to American Safety Programs and Training. Quick review of Chapter 35, Geriatric Emergencies. I hope everybody's staying well, happy, healthy, and staying a minimum of 6 feet apart during this COVID-19 situation that we got taking place. So let's do a quick review, very quick highlight of Chapter 35, which is Geriatric Emergencies. First of all, geriatric patients. Who are geriatric patients? Geriatric patients are defined as those individuals who are 65 years of age or older. What are some of the things we need to be concerned about geriatric patients? Lots of things, just like any other patient we have to worry about. Geriatrics are they're older, more experienced, very knowledgeable patients. A lot of times they can tell you exactly what's going on, and they know what they're talking about. They know their medications. They know why they're taking their medications. As compared to young people, they really don't understand why they're taking their medications. They don't remember their medications. The elderly usually understand. They know their medical history, and it's in their head. Whereas younger patients, they can't remember everything. So geriatric patients, for those who are able to speak to you clearly and concisely, and still lucky enough to still have their wits about them, they're some of the best patients you can deal with because they're wonderful people. So what are some of the considerations we have to do? First of all, we have to be communication techniques. Some of the communication techniques that you have to be aware of when you're dealing with geriatric patients is, number one, treat them with respect. They've been on this planet a lot longer than us. They've experienced a lot more. They have earned our respect. Whether this is the first time we've ever met them, the things that they've gone through are things that we have not gone through, and they've been on this planet longer than us. They probably experienced more bad and good than we have. Who knows? When we reach their age, maybe we'll experience as much as they do. But we're not their age. We're younger. We're there to take care of them. We're there to take care of them because either they or a loved one or a medical provider thought that they needed help. So that's why we're there. We're not there to judge. We're not there to criticize. We are there to help them as EMTs, no matter what the age of the patient is. But you need to clearly identify yourself. They want to know who you are. They want to know why you're there. Be aware of how you present yourself. Make sure you present yourself in a very professional manner. You want to be in uniform. Don't dress sloppily. Don't have your shirt hanging out and your shirt unbuttoned and your boots untied. Number one, that's very unprofessional as an EMT. Number two, doesn't put across a good presentation to the patient. Somebody who wants you to take care of them. Someone who you want to give them medication. Well, if you can't tuck your shirt and keep your shoes tied, what makes me think that you know what medication to give me to? What makes me believe that you know how to take care of me? Okay? Look directly at the patient and practice good listening skills. Give them the respect. When you're talking to somebody or somebody's talking to you, look at them in their eyes. It shows respect. It shows that you're listening to them. Okay? When they say something to you, repeat it back to them. And by doing that, if you repeat it back correctly to them, the way they said it, that signifies to them and they acknowledges that you are listening to them because you repeated back exactly what they said. If you repeat it incorrectly, they're going to go, oh, this young whippersnapper is not listening to me and they want me to trust them. They want me to trust them? I don't think so. So listen to them. Good eye contact. Okay? Speak slowly and distinctly. You don't have to talk really fast like this because they're not going to understand it. Talk a little bit slower. Talk very clearly. Make sure they understand every word that you're saying. Sometimes they're hard of hearing. Sometimes they may have one good ear, one bad ear. One time some of them might have to have multiple hearing aids in. Maybe their hearing aid battery is dead. Maybe they haven't put their hearing aid in yet. Maybe they took it out already for the night. It's 9 o'clock at night, and you're showing up at their house. They have a hard time hearing you. Take that into consideration. Okay? Give yourself time to talk to the patients. A geriatric patient is going to take a little bit longer to give you answers than the average patient. So if you need to give them an extra 10 seconds to answer a question, give them the 10 seconds. Show them their respect. And I guarantee you that the answer they give you is going to be a more concise, precise, and more detailed answer and a better informed answer than most of the other patients you're going to deal with. Okay? Not all, but most. Okay? Do not assume that the older patients are hard of hearing. Just because they're 92 years old doesn't mean you have to walk up to them and start yelling in their left ear, yelling in their right ear. They can hear you just fine. Just like you don't assume that a blind person can't hear. You don't go up yelling at a blind person at the top of your voice. They're blind. They're not deaf. Same thing with elderly people. They can hear you. Once they hear you, speak slowly, concisely, Don't use any medical jargon. Use everyday talk with them. That's what they understand. Okay? Give the patient plenty of time to respond to your questions. You're going to give them extra time to think about it. Give them extra time to answer. You're giving them extra time. You're taking more time to ask them the questions, so give them more time to answer the question. Okay? Listen to what the patient tells you. Okay? Listen to what they say. They're educated. They're adults. They've been around. They've been on the planet a lot longer than you. They know what they're saying. Okay? You ask them a question. They give you an answer. Listen to the answer. We're so used to getting roundabout answers from our patients that when we meet somebody who gives us a direct, specific answer to a specific question, that will sort of catch us off guard sometimes. Well, surprise, that's what a lot of geriatric patients do. Okay? They speak the talk. They talk the way we do. Maybe not with the medical terminology, but they answer questions very specifically. There's no roundabout answers. Okay? If you're going to do something, you're going to take a blood pressure, you're going to take vitals, blood pressure, pulse, respirations, BGL, look in their eyes for equal pupil reaction, and listen to lung sounds. Tell them what you're doing. Okay? They've met a lot of honest and some dishonest people in the world. They want to make sure they can trust you. And by developing that relationship, by developing that level of trust with your patient that we all have to do with all of our patients, tell them what you're going to do, tell them why you're going to do it. Okay? Don't talk about the patient in front of the patient to your partner like they're not there. The patient's right there. You ever seen in the movies, doctors and nurses are talking about a patient. The patient's like, hey, excuse me, hello, I'm right here. Okay, don't do that to your patient. Talk to your patient about the patient. Talk to them about them. Okay? They have a say in their care. Okay? There's a lot of common complaints, a lot of common conditions that can lead to death with a geriatric patient. And let's see, one other thing I wanted to mention. Let's see here. So communication techniques, yep, we just talked about it. Speak respectfully, identify yourself, be aware of how you present yourself, look directly at the patient at eye level, speak slowly and distinctly. Okay? Listen to the answer, explain what you're going to do before you do it. Don't assume that all elderly patients are hard of hearing. Okay? Geriatric patients are predisposed to problems not seen during youth. It's very common for an elderly person to have hip fractures. It's very common for them to have arthritis in multiple parts of their body. Arthritis slows everybody down. They're more likely to occur when bones are weakened and they have osteoporosis or they have an infection. Sedentary behavior, which means they stay in bed all day, they stay seated at a table all day, they watch TV all day, they're wheelchair bound because they don't get up and walk around. They're more prone to have pneumonia and blood clots, DVTs. Common conditions and the leading causes of death with a geriatric patient, great question for a test, can be hypertension, arthritis, heart disease, cancer, diabetes, asthma, chronic bronchitis and emphysema, and stroke. So take a look at those last, the two of asthma and chronic bronchitis and emphysema. Those are respiratory disorders. Okay? We all know what emphysema does. Alveoli lose the stretchiness so they can't expand when they're doing blood exchange, when we're doing respirations and other things in the lungs. Bronchitis, we know what that is. Asthma, spasm of the bronchioles and stuff like that. Diabetes, we know how diabetes affects every system in the body. You have hypoglycemia. What do we do in a situation like that? They can have cancer. The older generations tend to have a lot of cancer. Okay? They could be going under chemo treatment. They could be radiation treatment. Okay? Heart disease, COPD. They could have CHF. They could have had multiple heart attacks. Okay? Arthritis. They move very slow. Their bones crack. Sometimes a patient's moving around and you're wondering what's making more noise, the patient's body or bowl of Rice Krispies. Okay? They've got arthritis. Arthritis is painful. They could have had strokes. Okay, multiple strokes. So their mental capability might not be there completely. So So those are the common conditions. Some of the leading causes of death are heart disease, cancer, chronic lower respiratory disease, strokes, Alzheimer's, diabetes, and influenza and pneumonia. Changes in the body. A lot of the tissues in the body undergo a lot of changes, decrease in the functional capability or capacity of various organ systems, but it's normal and can affect the way the patient responds to illness, the way their kidneys function, the way their liver functions, how effective their cardiovascular system, their pulmonary system, their neurologic system. Okay. They have changes in, like I said, the pulmonary system. Airway muscular becomes weakened, alveoli in the lung tissues become enlarged, and the elasticity decreases, emphysema. And the body's chemoreceptors slow down with age as well. Pneumonia, they're very prone to pneumonia, or again, respiratory issues. Their immune suppression associated with age and increases the risk of contracting pneumonia, leading cause of death from infection in Americans older than 65. So pneumonia is pretty bad with them. They're prone to get pulmonary embolisms as well. As you know, pulmonary embolism is a condition that causes a sudden blockage of an artery or a venous clot in the lungs. Okay, the patients will present with signs and symptoms of shortness of breath and sometimes chest pain. You treat accordingly. Change in the cardiovascular system. Okay. Heartbeat slows down. Sometimes it beats up. Cardiac output declines, so they don't have that good of perfusion throughout all the organs. You got arteriosclerosis. Okay. Those all contribute to the blood pressure changes. Some of the additional changes that they get a buildup of that junk in the arteries and the veins, arteriosclerosis. Okay, so their blood, so it's higher chance of strokes. Get some of that stuff blocking off or breaking off. Increased risk for formation of aneurysms. Blood vessels in the heart, valves become stiff and degenerate. More prone to heart attacks. The classic symptoms of a heart attack are not often present in geriatric patients. Signs and symptoms of cardiovascular disease are not always the same. Signs and symptoms will differ from the right side to the left side. Men and women present differently. Women will have pain in the lower back, whereas men, it's usually always chest pain, left shoulder pain, and left jaw pain, or both-sided jaw pain. Okay. When you have right-sided heart failure, that's when fluid backs up into the body. When you have left-sided heart failure, that's when you have fluid buildup in the lungs. Let's see. Stroke. Stroke is the leading cause of death in older people. There's a lot of preventable risk factors. Smoking. Stop smoking. If they're a diabetic, if they have hypertension, if they're obese, and if they lack exercise. And we all know geriatric patients don't get that much exercise. Some of the uncontrollable factors are age, race, and gender. The difference of the two strokes, hemorrhagic stroke and an ischemic stroke. Hemorrhagic stroke is a broken blood vessel, causes bleeding to the brain. And an ischemic stroke occurs when blood clot blocks flow of blood to portions of the brain. So the ischemic is when there's a clot, decreasing blood flow, and hemorrhagic is when there's a hemorrhage and there's a bleed in the brain. Okay? If the symptoms occur within the past few hours, the patient could be a candidate for stroke center therapy. TIAs, we all know what TIAs are. Basically, the symptoms with transient ischemic attack can present with the same signs and symptoms as a stroke, but it's usually the signs and symptoms go away, resolve themselves within a couple of hours. Changes in the nervous system. Most common finding, they have changes in thinking, changes in memory, slower response to questions. So they do take a little bit longer to think about giving the answers to a question. The memory's not as sharp as it has been. And they slow down. And the way they think about things are different than the way they think about things 30 years ago. The brain shrinks, it decreases in weight. so therefore decreases in overall capability. And performance of most of the sense organs declines as well. Sense of smell, taste, touch. Vision, we all know that the vision decreases in the geriatric patients. A lot of them wear glasses. They get cataracts. They have decreased tear production, so they tend to have dry eye syndrome. Their inability to see things close up, so that makes them farsighted, so they've got to have glasses. Glaucoma, macular degeneration, and retinal detachment. So that's all happens with their visual acuity, depth perception, and their inability to accommodate the different light, bright lights, dark lights. Their hearing changes as well. They're hard of hearing. They may have one good ear, one bad ear, two good ears, two bad ears. They might have one hearing aid, two hearing aids, different styles of hearing aids. So that changes as well. They can't take loud noises as much as they used to. They're more sensitive to loud noises. Their senses in taste and touch. Taste decreases. They can't taste all the minute flavors of food. Foods that they liked 10, 15 years ago, they may hate right now, just the way that their taste buds have changed. Touch. They have a decreased sensation to touch and pain perception. They can't tell when it's too hot or too cold until it's sort of like almost not too late, but they should have noticed it a little bit earlier ago. A lot of elderly tend to get cold very, very easily. It takes them forever to warm up. That's why I always see the elderly people, they dress in long sleeves and long pants during a hot summer day. Because even during a hot summer day, for some reason, they still get cold. Their muscle mass decreases. If they're thin, think of how much insulation the body has. So they're going to get cold very easily, and it takes forever to warm them up. Dementia. We all know what dementia is. They get confused. They don't know what's going on. They don't know where they are. So when we're doing an evaluation of a medical or trauma patient, trying to determine that level of consciousness, the ALC times 4, person, place, time, and event, or the AVPU, it's going to be skewed, and you got to take that into consideration. So their cognitive abilities are going to be affected. Their social skills, they may not be as popular, or they may not be as talkative as they once were. And their psychomotor skills are going to be different too. They're not going to remember how to do simple motor skill things that they used to do. Dementia can have short and long-term memory loss. They can have a decreased attention span, unable to perform daily routines, show a decreased ability to communicate. They can appear confused or angry because they can't figure out what's going on, so they get frustrated with themselves because they were never like this. They weren't so indecisive. They could remember things. They could say what they wanted to say. Now they have a hard time remembering. They have a hard time verbalizing what they're thinking, and they get mad. They get angry with themselves. They have impaired judgment. They just can't make a decision. You want a cheeseburger or a hamburger? I'm not quite sure what I want. Okay? And they're unable to vocalize pain 100%, or they're unable to vocalize pain as well as when they were younger. They have a harder time describing it. Delirium is a sudden change in mental status, consciousness, and cognitive process. It's marked by the inability to focus, think logically, and maintain attention, and it affects 15 to 50% of hospitalized people over the age of 70. It's generally the result of a reversible physical alignment or metabolic causes, so hopefully they can get it taken care of with medications. Syncope, you know what syncope is? Okay, possible causes of syncope in geriatric patient: dysrhythmias and heart attacks, vascular or volume changes, and neurologic causes. The dysrhythmias and heart attacks, the heart is beating too fast or too slow, the cardiac output drops, the blood flow to their brain is interrupted. A heart attack can also cause syncope. So the heart's beating too fast, too slow, the blood flow changes, the cardiac output changes, and that affects them. Okay? Always treat syncope as a life threat. Okay? Vascular volume changes, medication interactions can cause venous pooling and vasodilation. The widening of a blood vessel, which results in a drop in the blood pressure and inadequate blood flow to the brain. Another cause of syncope can be the drop in blood volume because of hidden bleeding, such as an aneurysm. So if they have internal bleeding and nobody catches it, they can lose quite a bit of blood, and then they go to hypovolemic shock. Neurologic causes, syncope can be the sign of a transischemic attack, a TIA, or an actual stroke itself. Okay? But syncope is usually caused by some type of interruption of blood flow to the brain. We just discussed some of the changes. We really can't figure out what they are. So, treat the patient as a priority. Treat them for shock, position of comfort, high flow to keep them warm, rapid transport, keep an eye on their vitals, and keep the patient as stabilized as you possibly can during transport. Neuropathy. Neuropathy is a disorder of the nerves of the peripheral nervous system. Okay? Symptoms that depend on which nerves are affected and where they're located. It could either be motor, sensory, or autonomic. They have changes in the gastrointestinal system. They have a reduction in the volume of saliva, so they have a dry mouth all the time. Dental loss. They can lose a lot of their teeth or high quantity of their teeth, and they have to have dentures or partials. Sometimes they have a hard time speaking with those because they forget to put them in. They can have gastric secretions are reduced. Gastric motility slows. Diseases are common in the bowels, and they have impaired liver function. They can have a GI bleed, can occur in the upper or the lower GI tract, and that can result in inflammation, infection, or obstruction in the GI tract. Signs and symptoms: palpable pain, distended abdomen, and they're complaining of pain down there as well. Some of the specific GI problems in older patients can include diverticulitis, bleeding in the upper lower GI system, peptic ulcer disease, gallbladder disease, or bowel obstruction. Also, orthostatic vital signs can help determine if a patient is hypovolemic. Orthostatic vital signs: you take someone's blood pressure, pulse, or respiration when they're sitting down, and then they stand up. You take the blood pressure, pulse, and respirations again, and they're different. They could be higher, they could lower. They're usually lower. You ever do a thing where you're sitting down or you're lying down, and you stand up real quick, and all of a sudden you get lightheaded, you get a little bit dizzy? That's orthostatic blood pressure. Lying down, sitting, and then standing up suddenly, your body needs a couple more seconds to adjust to it. Okay? Acute abdominal, non-gastrointestinal complaints are extremely difficult to assess. They can just tell you, I have abdominal pain. You don't know why it is. It could be from an injury, an infection. You don't know what it is. You need to pinpoint where in the abdominal section, what quadrant it's in. Is it tender to the touch? Can you push down on it? Do they have pain when you push down or when you release? Okay. You have one that's called most serious threat to the abdominal complaints is blood loss. Abdominal aortic aneurysm, the old famous AAA, is one of the most rapidly fatal conditions. A AAA means you're bleeding to death in your body, and it's very difficult to save someone in a situation like that. Even doctors have said that if a person's having a AAA and they're in the surgical room, that they have a 50-50 chance of surviving. You have a bleed in your aorta. It can be either an ascending or descending. It's usually descending in the lower part of your aorta, and you start to get a tear, you start to get a rip, and it starts to bleed. And that's where the most pressure is in your system, is in your aorta. And if that starts to bleed with every time that heart squeezes, it pumps blood out of your system and it goes into your abdominal cavity. You're bleeding to death, and it's extremely painful. Okay, some of the changes in the renal system, it affects the kidneys directly. A reduction in renal function, a reduction in renal blood flow, and tubular degeneration. The tubes from your kidneys down to your bladder could be degenerating, and they can't transport the waste as easily, so you get a backup. Okay, you could have decreased bladder capacity. That's why they need to go to the bathroom every 10 or 15 minutes or every half hour, because their bladder just can't hold the amount of urine that it used to. Decline in sphincter muscle control. Sometimes they're void their pants or they're voiding their underwear because they can't control their bowel movements as well as they used to when they were younger. So they're going to be incontinent. They may urinate in their pants because they can't, the muscles in the urinary tract, they can't retain the urine. So they need to go to the bathroom. That's why I see a lot of ads on TV for adult pull-up diapers, because when you get older, a lot of people out there can't control their bowels or their bladder as well as they used to. So they wear those. Let's see, reduction of thyroid hormones. They can be, if they're diabetic, It's more difficult to control the diabetes when you get older because you don't eat as much, so you don't have that much energy going into your body. So if you're diabetic and you control your diabetes through medication, your medication will be probably changing every couple of months because your blood sugar is going up and down. It's hard to get it regulated. If you take insulin, you need to make sure that you eat on a regular basis. You need to keep an eye on your calorie and your sugar intake. And that's more difficult with the elderly, especially if they live by themselves, because they tend to forget because they have dementia. They forget to take their medicine. They actually forget to eat. They don't feel hungry, so they don't eat. But yet they take their insulin. So it's tricky. It's difficult at times. It really, really is. Elderly people are more common to get UTIs and pneumonia. There's a lot of changes in the musculoskeletal system. They have a decrease in their bone mass. So the decrease in bone mass, that's why elderly people tend to get short, a little bit shorter. Their bones break more easily. They have osteoporosis, which is a type of arthritis in their joints and their bones. A lot of people tend to have osteoarthritis in their knees, and it's very common for an elderly person to have their knees replaced, a total knee replacement. Okay. Let's see. Changes in the skin. The layer of fat that's under the skin becomes much thinner. The proteins that make up the skin, pliable, decline. So that's why an elderly person, their skin might be a little bit more leathery. The elasticity of the skin declines. Bruising becomes very easy. It's very easy for them to become bruised. They may just rub up against a door the wrong way, or a door jamb, or a dresser, and they get this big black and blue mark. Sometimes they're on blood thinners if they've got a heart history, and those blood thinners will make it very easy for them to bruise. A bruise may take months to go away. When a younger person, the bruise would be gone in about 2 or 3 weeks. They're very prone to skin tears, and that is if you squeeze them too hard when you're trying to lift them, you can actually rip the skin. And sometimes that's caused by a lot of the medications that they're on as well. And their sweat glands do not easily respond to heat. So that's why they tend to overheat sometimes, because they're not sweating as much, taking advantage of when you sweat, the perspiration comes to the top of your skin, the wind comes along, it blows away, that's what cools off your skin. You got pressure ulcers. Pressure ulcers are very common if somebody is bedridden or they spend a lot of time sitting down. If they're in their bed 24/7 or 18 hours of every day because they don't get around that much, they're going to start getting sores, bruises on the part of the body that's lying in the bed, or on their butt and their legs because they're sitting all the time. They've got to get up. They've got to exercise. They've got to move around. If you have a patient who has bed sores or bruises or pressure ulcers, you got to pad it with something soft to help reduce the pressure on that area. Toxicology. Older people are more susceptible to toxicology because of decreased kidney function, altered gastrointestinal absorption, and decreased vascular flow to the liver. Decreased liver function makes it harder to detoxify the blood and eliminate medications and alcohol. So their livers are not as effective when it comes to filtering the blood, and it takes it longer to do it. So it takes longer for the medications to get through their systems. Okay? Typical over-the-counter medications can have negative effects when mixed with each other or when herbal substances, alcohol, and prescription medications. A lot of times, elderly, the geriatric patients will go to 2 or 3 doctors, and they get different medications from each doctor. I think it's called polypharmacy, when a person uses multiple pharmacies to fill prescriptions. And if Dr. A and Dr. B both prescribe medications and they don't know which the other doctor is prescribing them, Dr. B might prescribe this person a medication for the heartburn that the patient is having, and it'll have a bad interference with an over-the-counter or prescription that Dr. A is giving the patient. So that's why it's important for patients to know their medications and to carry a list around with them or take a picture of them with their phone. They can show the other doctors, well, these are my medications, and they can document it. And hopefully, if they can combine all their medications out of one pharmacy, if the doctor doesn't catch it, the pharmacist will catch it, because pharmacists are the most knowledgeable people on the planet when it comes to drugs and their interactions and what they're made out of. And they'll know if this drug is going to have a bad reaction when mixed with this drug. So they'll catch it when they're filling the prescription. They'll call the doctor, notify them, and suggest to the doctor other medications that have the same therapeutic effect as the medication that the doctor originally prescribed, but will not have the severe interaction with the drug that the other doctor is prescribing. So, polypharmacy, use of multiple prescription medications by one patient. Medication noncompliance, when you get older, due to financial situations, you may not be able to have the money to buy your inhaler, your MDI, your metered dose inhaler, your albuterol, or your ProAir. So you're going to have difficulty breathing every once in a while, and you show up and say, well, Mr. Johnson, who's 86 years old, why are you having difficulty breathing? What's going on? And the wife says, well, we didn't pick up his prescription this month because we don't have the money. One inhaler that lasts 45 days costs us $165, and we just don't have the money. So you're being called for difficulty breathing because they're not taking their medication for financial reasons. Okay? They may not be able to take the medication because they can't open the container. They have childproof locks on them. Okay? Or they may have impaired cognitive vision or hearing ability. They may not be able to hear what the directions are. They may not be able to read the directions because they can't read it. So they just guess what the directions are, and they're overdosing, they're over-medicating themselves or under-medicating themselves, or they just don't understand what they're reading. Okay? So that does it for the first half of the 60-minute class. I'm at 31 minutes, so this is part one. I will discontinue here and pick up with part two. Thank you. Bye-bye.